Thank you very much for your introduction. Assalamu alaikum, everyone. No, is there any session after this or one session? The last sessions are always good because then it's the time for dinner. So let's see. I hope there are a lot of people online. Anyway, I was asked to, if I can present something on the long-term outcome in CML-CB patients, chronic phase patients, frontline, second generation TKI. So I'm not here to convince you what to do. I'm here to present some data, and then you can make up your mind why is there any rationale for using a second generation TKI up front. I'm not going to say what I do. I may do it differently, but this is what the data would show. So looking at this as a role and rational upfront therapy for the second generation tyrosine kinase inhibitor, we all know that patients have been using imatinib for a long time. Just to give you some idea about the Saudi Arabia data, it's usually about 130 or so patients, or maybe now 150 the base, because I don't have the update on this one, for the total disease burden every year, new patients. And we see about 1/4 in King Faisal in Riyadh, about approximately 30 to 40 patients, new patients every year. And there are referral cases of resistance and intolerance. So second generation tyrosine kinase inhibitor not only is getting used as a intolerance or in patients with resistance, but also upfront. So a lot of times the patients who approach or are referred to us have already gone through a second line as a first upfront use. So we all know that it's revolutionized. Chronic myeloid leukemia treatment is like a chronic disease now, like hypertension or diabetes. People take it for drugs. I have patients who have been using this medication for the last 20 years now and remain in major molecular response, deep molecular response. I have patients in treatment-free remission. The longest one is approximately 8 years now. So the 10-year survival rates are anywhere from 83 to 93% based on how they respond and what they maintain as their response. From the very beginning, since the IRIS data was published, it is very well documented that the time to cytogenetic and molecular response has shown to predict the long-term outcomes. So the earlier their response to cytogenetics and earlier their response to molecular achievement, they do have a better outcome. And deep molecular responses also, of course, afforded select patients to discontinue therapy, which we call TFR, or treatment-free remission. So what we'll do in this talk is to see whether the time to cytogenetic molecular response is different between the first and second generation TKIs, that you may take this data and make a decision on what you need to start the patient on, and whether the deep molecular responses are more or higher or deeper molecular responses with the second generation, so you can make a decision for a treatment-free remission. The survival of adequately managed response patients is determined more by comorbidity. So this is from the original study. So not all patients, you cannot have one box and everybody's in the same box. So there are patients who are young, there are patients who are old, there are patients who have cardiac abnormalities, patients who are liver abnormalities, chronic kidney disease. So comorbidity index plays a strong role in the outcome. So that helps you in making a decision what kind of the first or the second generation tyrosine kinase inhibitor you want to use based on their Charleston comorbidity index, whether it's hypertension, diabetes, cardiac disease, history of pleural effusion, pulmonary hypertension, chronic smokers. We have hookah smokers of 50 years down the line. So the NCCN guidelines has approved from many years now the low risk and the intermediate or high risk. All of them are approved as a first line, and they are all category 1. Maybe the low risk, they say the preferred regimen is imatinib, and then of course the other ones, bosutinib, dasatinib, nilotinib. Now these are labeled as put in this way by their the way that's by the letters, not necessarily which one is the first one or some. It is only alphabetical. That's why. So bosutinib, dasatinib, nilotinib. If you have intermediate or high risk score, then they say that the preferred regimen may be a second generation tyrosine kinase inhibitor, but the first generation, of course. And a lot of us use first generation even in intermediate or high risk. But that's what the NCCN guidelines. And if you look at the risk calculation table, you can do any scoring. So CUL score was based on the time of the interferon although they have validated this also in the analysis in the tyrosine kinase inhibitor, but the ELTS score, which is the UTOS long-term survival score, is based on the current therapy of the tyrosine kinase inhibitor. In my practice, I use only ELTS. I don't use so-called score anymore because in this score, the patients who were in the high risk so-called, a lot of them moved down into the intermediate, and a lot of the patients who were in the so-called intermediate moved down into the low risk so-called score. So based on this one, anyway, the updated guidelines of NCCN has not changed. If you still look at it, the primary treatment, the low risk, the way you calculate it, ELTS or so-called, still a preferred regimen may be imatinib, but second generation tyrosine kinase inhibitor in alphabetical orders, they're listed over there, and also all of them are category 1. So there is no issue that some would say that it is not, no, all of them are recommended, but maybe imatinib is preferred. And on the other side, if they're intermediate or high risk score, then the preferred regimen apparently is a second generation, because as we'll look into the approach to achieve a cytogenetic response or a molecular response earlier time points. To give you a brief statement, the results of all second generation TKIs, whether nilotinib, dasatinib, and bosutinib, and now there are others also, are no different compared to first generation like imatinib in long-term overall survival, because there is availability of so many drugs and the response is good unless they develop resistance to all of them. But efficacy and outcome may be different depending on the treatment goals. So your treatment goal should be an objective. When you see a patient, there could be a young female who wants to get pregnant or get married in the next few years. There may be some old patients who do not have no other medical illnesses and don't care what you start with. So you have to make a decision which patient is going to tolerate which drug and what your goal is. Whether a younger patient is more for a TFR or an older patient is more for TFR. And this is very difficult to make this decision sometimes, because an elderly patient also is a very good candidate for TFR, because you don't want him to be on this drug which have cardiovascular side effects for a longer period of time. So there is no hard and fast rule that the younger patients are better for TFR, or older patients should not go on TFR. So all of them are approved as first line, preferred especially for the high risk so-called and ELTS. So what is the goal of therapy? For example, for the cure, we know very well that 50% of the patients will achieve a deep molecular response beyond a major molecular response. And if you get them into a TFR range, half of them will stay as a treatment-free remission on a long-term follow-up. So the overall cure is about 20 to 25%. When you look at the overall picture, 80% will still have to be managed as a successful chronic disease management, just like hypertension or diabetes. So you have to really select a drug that you think that if the patient fails a TFR, if that was your goal, then is the patient going to continue on this therapy for a longer period of time without going through any side effects, or significant side effects, should say. So successful chronic disease management is also as important as a treatment-free remission. Now this is again from a summary of a longer term follow-up on the TKI discontinuation trial. So if you look at these patients ranging about 100 plus, the largest one is the Euroski, which is the lowest one on this table with the largest number of patients. And when you look at the time point that the requirement to stop a drug is anywhere from 12 months to 2 years. Most of the older studies use at least 2 years of either undetectable or a deep molecular response of 4.5 or 5. But lately the trend is that as long as the patient gets an earlier major molecular response, and they maintain a deep molecular response for a year or two, is beyond 3 to 5 years is a time point for when you can offer them a TFR, because the studies have shown that the duration of use of TKI is also important, not only the deep molecular response, because we have some patients who have achieved a deep molecular response or undetectable at year's time, 1 year of use of TKIs, but they are not a candidate of TFR. Why? Because the duration is also important for how long they have to use. So generally now the trend is the drug should be used for at least anywhere from at least 3 to 5 years before you have to have a year or 2 years of 4.5 and beyond reduction in their transcripts. When you look at the treatment-free remission rate, it ranges anywhere from 40% to 50%, some of them 61% to 30 mg, but the long-term follow-up, which are like 5 years of the eNest freedom and eNest top, is about 43%, and the shorter term are maybe also the same. But when you look at the STIM study, the one on the top, which is the longest term follow-up, they continue at some time point lose the response, so they are about 38% or so. So do the results from the comparative trial help in selecting the frontline treatment among the first versus second generation? We know that survival by 3 months, some centers did show 3 months earlier, less than 10% did make a difference, but the major trials also have some evidence that there is an advantage, but did not show. But 6 months time point is probably the best time point, whether you can use BCR-able IS transcript of less than 10%, more than 10%. So it's difficult to make a decision at 3 points. I do not do it, and I would not recommend you to switch a drug at 3 months unless there is absolutely no hematological response also. But 6 months is a very fine time point, and most of the studies and most of the guidelines are moving towards that direction to that 6 months is a better time point of change of the drug if they are more than 10%. But you have to understand that even in the IRIS study, the patients who went on to have a deep molecular response or major molecular response at 1 year, even if their BCR-able was more than 10%, and they achieved a major or deep molecular response at 18 months even. So what about the consideration of choice for second generation as a frontline based on the percentage of patients eligible for TFR? Do you expect that there would be expected higher percentage, or is there an expectation that there will be earlier achievement of deep molecular response? If that is an expectation, then one should consider in select number of patients upfront on the second generation tyrosine kinase inhibitor. And as we discussed already, the deep MR, that is 4 or 4.5, is a prerequisite for many discontinuation trials. So when you look at the decision trial, the molecular response at 3 months was more, 84%, as compared to imatinib, which was 64%. But that is not at that time fine point as 6 months. And the same if you look at the first line treatment in chronic myeloid leukemia with EMR in the eNest, which is the nilotinib, also a whopping 91%, much higher, and the imatinib remains the same as the previous trial as decision, but apparently a significant number of patients did achieve a 3 months earlier early molecular response. Even for the before study, the bosutinib also the same, the imatinib remains the same, and bosutinib not as high as the nilotinib, but did have advantage in getting patients into an earlier molecular response. So what about by 1 year and 4.5? Again, no MR4 in bosutinib, 8%, 4.5, and 3% in imatinib. So obviously this is not a goal anyway for the start of the TFR. What about the 5 years in decision? Again, 4.5 was in 42%, and in imatinib also 33%, a difference of 9%, which is not that great. But this is just the point to make is that you get 42% of the patients, but eventually these patients will slowly tend to lose their molecular response and get back onto the medication. So 20%, as I put earlier, is actually the operational cure. So this is the 9%, but there seems to be continuous maintains a difference between the response as the years pass by, about 9%. When you look at nilotinib also the same, the difference is actually higher starting from 1 year, and approximately 23% difference between imatinib and nilotinib by 6 years. So 56% of the patients did achieve MR 4.5, which is a prerequisite for treatment-free remission. And the cumulative rates so continues to go by 12 months with 21, by almost close to double by 24 months. And when you look at the first line treatment CML, treatment-free remission, on frontline nilotinib achieved 4.5 earlier than on imatinib. So the overall years, when you start making a decision that this patient is a candidate for TFR, I'm going to offer them TFR at the next visit in this next 6 to 1 months. Imatinib took a little bit longer, and nilotinib took about 3.8 years. And as I said, that the duration of use of TKI is also very important. It has to be at least 3 to 5 years before you put them on treatment-free remission. There is some tendency, and I'm not going to discuss it over here, in combination of drugs where they get patients earlier, deeper molecular response and tend to put them earlier in the treatment-free remission. So ENEST freedom, patient disposition, just to, because interesting to look at this one, more than 2 years on frontline imatinib, they went on to have a consolidation phase of 52 weeks, and as long as they maintained their 4.5 log reduction, they went on to go to a TFR phase. And almost close to 90% of the patients actually completed the consolidation phase. So they went on safely onto a treatment-free remission. And this is what it is, ENEST freedom, 144 weeks, a long-term follow-up treatment-free remission, almost 46.8% or 47%. Nearly 50% of the patients that you selected for TFR remains in remission, which is actually good. But when you look at the whole picture, it is operational cure still about 25% of the total number of patients that you start them on these medications. The good thing is, the moment they lose, as optimal response for any chronic myeloid leukemia patient is a major molecular response. So as soon as when they lose a major molecular response, you put them back onto the same medication, and almost all of them will achieve a major molecular response. 99% almost, and 92.3% will regain the 4.5 log reduction, which was actually the time point that you made, the value that you used for starting the TFR. So it is safe when you counsel a patient. It has to be mentioned in your documented notes, because you're going to stop the drug. When you counsel the patient, you should let them know that in case we're going to follow you very closely, and in case if you lose a response, the chances of getting a major or an optimal response is 99%. And with the same deeper molecular response, almost like 92% to 93%. And just to, sorry, I think I have to, how to go back. So also, it does not take that long. I forgot to mention that it does have maybe within a 12 to 14 weeks or so, patients, and the regaining of the major molecular response is very short also. So it's not going to take another year for patients to lose a major molecular response. It's within like weeks. The timing is getting back into an optimal response is actually within weeks. 7 weeks for major MMR, and a median of 12.9 weeks in getting the MR 4.5. So in summary, the second generation TKIs as frontline shows a better efficacy. There's no question. This has been published on the comparative trials. Safety profile is manageable. There may be a different safety profile. Imatinib may be somewhat safer, but this safety profile is manageable. Earlier molecular response and deep molecular response on upfront second generation leads to better progression-free and possibly overall survival, although there is no clear-cut indication of an overall survival difference yet. Especially except maybe patients who achieve a deep, very deep molecular response compared to patients who have achieved only a complete cytogenetic response. Whatever the selection, the earlier MR and the deeper MR on second generation TKIs as frontline leads to a higher number of patients eligible for TFR. So one can make that case that if I'm going to get a higher number on deeper molecular response, I can select a larger number of patients to go for a treatment-free remission. And second generation will lead to earlier time point decision for TFR, as I showed you, 3.8 for the second generation, the nilotinib as compared to imatinib, which was 5.3 months years, I think. But again, 70 to 80% of the patients will have to be managed as chronic disease, because people tend to lose their responses. Understanding efficacy, tolerability, adverse events, and comorbidities all have to be taken into account when you make a decision upfront for a second generation TKIs. because eventually, as I said, the curative operational cure is about 20%, but you can look at it in two ways. Either you say that, well, this only 20% will be cured, but also you know that you have been able to subject patients for treatment-free remission attempt approximately 50 to 55% of the patients in the second generation as compared to 30 to 35%. So higher number of patients have been given a chance of treatment-free remission. They may or may not, all of them obviously will not maintain a long-term treatment-free remission. So overall, still 25% or so patients will be able to manage as an operational cure. I think that was it. This is King Faisal, our building, and this tall building is the King Abdullah Center for Oncology and Liver Disease. Thank you very much.